Black women have the highest breast cancer death rates of all racial and ethnic groups, and a 41% higher rate of breast cancer death than white women. Black women with breast cancer are 41% more likely to die from the disease than white women. African American women have a 31% breast cancer mortality rate, the highest of any US racial or ethnic group. Among women younger than 45, breast cancer incidence is higher among African American women than white women. Only 69% of Black women start treatment within 30 days of diagnosis, compared with 83% of white women. Breast cancer is the most commonly diagnosed cancer among Black women. It is the second most common cause of cancer death among Black women, surpassed only by lung cancer. Today, we have the pleasure of having Dr. Lannis Hall to discuss African American women and breast cancer. Dr. Hall is the Director of Radiation Oncology at Siteman Cancer Center at Barnes-Jewish St. Peter's Hospital, and the Associate Professor of Clinical Radiation Oncology at Washington University School of Medicine. In addition, she is the leader of clinical trials at Barnes-Jewish St. Peter's Hospital. Dr. Hall graduated from Howard University College of Medicine Medical School in 1992. She was the clinical trials leader for the program to eliminate cancer disparities at Washington University School of Medicine. Her specialty is radiation oncology. She treats cancer by using different forms of radiation to detect and kill malignant cells. This treatment is often combined with surgery and chemotherapy. Without further ado, I present to you my link sister and friend, Dr. Lannis Hall.
Deanne, thank you so much for such a warm welcome. And I just appreciate traveling this journey with you, because you have been just as important as I, as we develop how to help women hear the message about breast health. So thank you for your passion and your dedication. I also want to thank Rosalind Daniels and Ross Fleming, Kappa Alpha Psi, as well as the whole Black Health Matters team. It is an honor to present today, and this is a perfect time for this conference. We know that last year, many men and women correctly sheltered at home and did not engage in the healthcare system. But what we also know is that there were significant screenings for prostate, colon, and breast that did not occur. And what we're seeing this year, unfortunately, is very advanced and incurable cancers, some difficult to treat. And what we want to do is spread the message to get back into your healthcare provider. And today we are going to focus in on breast cancer. So I'm going to share my screen and go into I want to make sure this is the right screen and that you just see one large slide that has the title on it, and it's not two different slides. So my hope is that you just see one large slide. I'll check in the chat. Thank you very much. Okay, I see that. All right, so I want to start with a bit of good news, because originally, if you look at curves for over the last 40 years, the mortality rate for men and women was steadily rising. This is the number of deaths in men as well as women. But then at around 1990, notice that this curve began to drop. And so we were flattening the curve, which is what you've probably heard a lot because we've talked about it with COVID. And so the mortality rate began to decrease. So much so that since about 1991 to 2016, 1.8 million deaths in men have been avoided and 800,000 deaths in women. And the majority of these deaths have been avoided due to personal health choices, like avoiding tobacco use. So not putting yourself at risk for lung cancer. But also what happened at around 1990 and between 90 and 95 was the introduction of PSA for prostate cancer screening, colonoscopies, and other ways to detect colon cancers, as well as routine adoption of mammography screening. So that's the good news, because these 2.6 million people are uncles and grandfathers and neighbors and other loved ones. So it matters what we do. It matters if we screen. It matters what we choose to do and what we put into our bodies. We're going to talk about breast cancer. And as Deanne correctly stated, there are about 280,000 new cases of breast cancer that are expected to be diagnosed this year. It's the most common cancer diagnosed in women, and it is the second leading cause of cancer death in women after lung cancer. It's expected this year that 43,000 women will die of this disease. And risk factors are defined as modifiable and non-modifiable. Significant risk factors include things that we can't change. Those are the non-modifiable risk factors. And that is that your sex, you're a woman, you can't change that. Your age and your family history. So notice that in men this year, about 2,600 cases that will be diagnosed. That's less than 1% of what we see for the diagnosis in women. So breast cancer is a disease of women. And the average age or median age for white women is 62, 57 for African-American women. So 5 years younger at the time of diagnosis. So there's an earlier age of onset. Now, family history only contributes to about 15% of the new breast cancers diagnosed. So this is one of the misnomers, and that is that if I don't have a family history, I don't have a risk for breast cancer. The majority of breast cancers diagnosed do not have a family history. Now, hereditary or inherited breast cancers means that there is a change in a gene. We call it a mutation that can either be passed down from your father or from your mother. And that gene can increase your risk for breast cancer. The most common is BRCA1 and 2, but there are many other genes. Well, inherited mutations only represent about 10% of these breast cancers. You also can't really change if you had a history of previous biopsies because you had abnormal growths. So again, many of our risk factors are non-modifiable, but we then get into risk factors that we can do something about, like hormone replacement therapy that we might choose to take when we go into menopause because we had those annoying hot flashes and other changes that occur. Your diet, whether you consume alcohol routinely or not. And the big one is weight gain and obesity. And we will get into that more in just a moment. The most common misconception in terms of symptoms is that a breast cancer is usually painful. No, it's usually a painless mass. And that's like a question if we had a survey at the end. You can have a fullness or change in the contour of the breast. So it can feel heavier, or you can notice a dimpling. You can also have underarm fullness, swelling, or mass, nipple inversion or bloody nipple discharge, that is not normal. And redness and swelling of the breasts, where it feels heavy or you feel like you have an infection, that should demand an immediate appointment with your healthcare provider, because it can be a more aggressive type of breast cancer called inflammatory breast cancer. Now I'm going to spend a little bit of time on this graph. I know it is busy and I only have 2 of them, so this is one of 2. But this is important because these, it tells a story here. These are mortality rates for African American women, which is in blue. So, and in green is white women. And then plotted here on the x-axis is years 1975 all the way to 2012. Notice here in 75 or 80, the mortality rate, and that's a rate, was no different between African American women and white women. But then as the years went on, African American women's curve went up above white women and has remained up. This is a disparity. This is a difference we don't want to see in survival. And it is a 40% higher mortality rate that we have seen now for over 20 years in African American women compared to white women. Remember, again, we started out the same in 75. So as we developed the routine use of mammography in 85 to 90, we developed some amazing advances in the treatment of breast cancer called endocrine therapy and targeted therapy. There has not been, unfortunately, the same benefit in these advances for African American women as compared to white women. So not all women have benefited equally from these advances. And that is what we need to hone in on and talk about a little bit further, because why is that? Well, this is my second busy slide that I told you about. And when I first saw that curve, my perception was that the 40% higher mortality rate in African American women would be evenly distributed across all 50 states. But that's not the case. And this actually at the end has more questions and more hope for us than initially thought. Now, this is a waterfall plot, kind of like a waterfall, but having a wide bar graph is not a good thing. The way to read this graph is that in Louisiana, 66% higher mortality rate in African American women compared to white women. In Mississippi, the breast cancer mortality rate is 62% higher in African American women compared to white women. But I want to draw your eye down to Massachusetts, Connecticut, and Iowa, and Delaware, Minnesota, where this light blue means mathematically we don't really see that much of a difference. But these are states where you don't see a 40% or higher mortality rate. You actually see almost, not quite, but almost equivalency. So this gives us hope. What's going on in these states down here compared to these states? And one of the glaring differences is what I would deem as overall access to care. These states early on, Massachusetts, Connecticut, Delaware, early on had robust systems for providing insurance and screening availability and treatment options for people diagnosed with cancer, whereas many of these states up here, Louisiana, Mississippi, Missouri, Tennessee, you're still fighting to expand Medicaid or not expanding it at all, or limiting the number of people who you offer health insurance to, even though they have good, they are working full time and have jobs. They just don't have a health insurance benefit. So this is when we get into what's called social determinants of health: where you live, where you work, do you have good food choices or not, that impact your survival from different malignancies and diseases. So I want to make sure we know about the National Breast and Cervical Early Detection Program because it is available in all 50 states. If you put this into your web browser, National Breast and Cervical Early Detection Program, and then put in your state, you will have information on where you can go to see if you qualify for free breast and cervical cancer screening for women. And there are income guidelines. The ages are generally 35 to 64, as I said, offered in all states and DC. And the goal is for people who don't have insurance for you to be able to get screened. But what is the gem of this program? If an abnormality is found, you get enrolled into Medicaid, so you now have insurance. And so this is incredibly important because most screening programs just offer that screening. This offers a way for you to get your surgery, radiation, chemotherapy, medications, and any other prescriptions covered. I finally want to show this graph before I get into something a little bit easier for us to digest. So it's not all graphs. We're about to leave this. Is the importance of making sure our younger women know that they cannot ignore their breast health. This is not a disease of older women for many women. Over a third of newly diagnosed African American women are diagnosed under the age of 50. In their 30s and 40s, I've had several women in their 20s. So the key here is when you are younger, compared to white women, in this age group of 35 to 44, African American women had a 290% higher mortality rate. And this is in our most populous county in the state of Missouri, but this could be overlaid in any major metropolis. Younger women have even a larger disparity, a higher mortality rate compared to white women. And this is why you really have to know your risk as women get older, get to 65, when everybody pretty much can qualify for Medicare if they've been working some part of their life. We see again the benefits of having good health insurance. So finally, you might say, what is it about younger women, younger African American women, that might be driving this higher mortality rate? And that just gets into the biology of breast cancer. There's 4 main types. So when somebody tells me I've been diagnosed with breast cancer, the first question I want to ask is, what type? The most common is luminal A, and we'll just know that that means they have 2 antennas, typically an estrogen receptor antenna, meaning estrogen kind of feeds it, or progesterone, another hormone, feeds it. And that's for Black and white women, but we're going to concentrate on triple negative breast cancer. And triple negative breast cancer is a subtype that is defined by what it does not have. It does not have an estrogen receptor. It does not have a progesterone receptor. And it also doesn't have this antenna for a protein called HER2. These are all things that drive and transform a normal cell to a cancer cell to proliferation of cancer. And we've learned how to manipulate these receptors. But in triple negative breast cancer, there's not these 3 most common receptors. And 1 out of 4 African American women will be diagnosed with triple negative breast cancer versus 1 out of 10 white women in general. And when we talk about younger African American women, 1 out of 3 premenopausal African American women will be diagnosed with triple negative breast cancer. So let's talk about triple negative breast cancer. What's the problem? Well, it's associated with higher rates of relapse recurring after treatment. Relapses usually occur early within the first 3 years. And when the relapse occurs, it's in organs that are difficult to clear from the cancer, like lung, liver, and brain. The chemotherapy may be less effective after a relapse. The good news is there are over 700 clinical trials ongoing nationally that are evaluating novel therapies for triple negative breast cancer. So I have to do a plug about these clinical trials in a moment, because these targeted therapies that we found for those other 3 types of breast cancers, including tamoxifen, aromatase inhibitors, Herceptin, and other agents, it's really because of clinical trials that we now have an incredible improvement in the prognosis of these other 3 types of breast cancer because of the breadth and the depth of clinical trials. The good news is triple negative breast cancer has promising therapies like PARP inhibitors and vaccine trials. And so clinical trials are important, because if you have received any treatment for high blood pressure, cancer, or an infection, then you benefited from a clinical trial. Tens of thousands of women, men, and children of all ethnic and racial groups participate in clinical trials every year for prevention, for screening, for diagnosing and treating disease. And diverse participation is necessary to ensure that the outcomes are beneficial for everyone. And what we found in research is that women and men who participate in clinical trials do better. And partly it's because you have layers of healthcare providers who are looking at your chart and making sure that you're followed closely, making sure you're not having adverse side effects. And that all means that several layers of different doctors and nurses, that you're getting the best care. So let's do some talking points. This gets a little bit easier. This is what I absolutely want you to remember, because at the end of the day, we want to reduce unnecessary pain and suffering caused by breast cancer. So let's follow these breast tips. If you are average risk, then you should begin screening at the age of 40. Women with a strong family history of breast or ovarian cancer, a history of previous biopsies, or a known mutation should discuss when to begin screening with their healthcare provider. Recommendations vary, but some women may need to screen at the age of 20. So if you know, hey, I've got like 3 relatives, and they might be first degree relatives, like my mother, my sister, or daughter who has had breast cancer, you may need to be screening earlier. And it's important to find a facility that offers 3D mammography. 3D mammograms have a higher detection rate and unnecessary callbacks. No one wants to be called back for additional imaging. And 3D mammograms help to reduce those callbacks. I know in Missouri, there's no increased fee for 3D mammography, and that is the case in many other states. Practice breast self-awareness. Know your breasts. Pick a memorable day to examine your breasts routinely in the shower or while lying in the bed, and alert your healthcare provider for any changes, including a new mass, a nipple discharge, heaviness, change in color, armpit swelling, or unusual pain. And remember that breast cancer is usually not painful. I suggest you do it every month, because, otherwise, many times you'll just get out of the habit of even knowing if how your breasts feel. So just pick a day, your birth date, mine's on the 17th, and do it monthly. Mammograms reduce mortality. That's why you hear mammograms save lives. By detecting breast cancer on average 2 to 3 years before you will ever feel it. Think about that. You can do a breast exam every day, but a mammogram on average picks up a breast cancer 2 to 3 years earlier. And it's also important to read the results of your mammogram, because let's say every woman now gets a score or a category score of their breast density. And that density indicates the amount of connective tissue or glandular tissue as it relates to fatty tissue. And connective tissue and glandular tissue looks like white on a mammogram, whereas fatty tissue is wispy. Notice it's hard to see if there's going to be a mass in all of this whiteness. So this area is called breast density, or higher breast density. And there's 2 categories: heterogeneously dense and extremely dense breasts, where we know that for women with increased breast density, there can be a higher risk of developing breast cancers, and the mammogram may be less accurate. So that's when you may have to advocate for yourself and say, hey, my report says I have extremely dense breasts. That means I might need to have an MRI or an ultrasound or some additional imaging to make sure that we have clarity on what's going on. So look at that report. And if you have category D or extremely dense breasts or heterogeneously dense breasts, and you have a strong family history of breast cancer, you may need to undergo MRI screening or an ultrasound. Because at the end of the day, to stop cancer, you must spot cancer. So you have got to detect it in order to stop it. So what can we do to reduce our risk? Avoid weight creep. Your food choices matter. So weight gain throughout our adult years increases our risk for developing breast cancer. So what does that mean? If you finish high school at the age of 18, you weighed a certain weight, the goal is not to gain over 20 pounds in your adult years. I'm gonna tell you, I know that's hard. And for most of us, we aren't doing that. So that means that most of us are engaging in weight creep. Every decade, we may put on 5, 10 pounds. So by the time you're 50, you might be up 30, 40 pounds. Well, that increases your risk of developing breast cancer later in life. So it's important to think about what you're eating, because your diet is always going to be so important, the most important item in losing weight. Consume 5 to 9 fruits and vegetables each day. I can't tell you how important this is. I mean, it's hard to get it in just with each meal. So I've often said you've got to either adopt smoothies or salads. But women who consistently consume a high amount of fruits and vegetables in some of our largest studies have a lower breast cancer risk. Vegetables high in carotenoids like kale, spinach, carrots, and bell peppers are particularly important in reducing breast cancer risk. Exercise 30 minutes daily to reduce your breast cancer risk. 30 minutes of purposeful walking, that's all you have to do. You don't have to do an Ironman or go out for a run, but exercise routinely 5 out of 7 days a week. And ideally abstain from alcohol. Even one alcoholic drink every day increases your risk of breast cancer. So limit your alcohol use. And then for breast health, remember hormone replacement therapy. I know when you go through menopause, it is hard. The hot flashes, just not feeling like you're quite as bright. But hormone replacement therapy, if you're going to do it, take the shortest duration possible and the lowest dose, because we have consistent data that when you're taking a combination of an estrogen and progestin, it increases your risk for developing breast cancer the longer you take this hormone replacement therapy. And know your family history. Sit down and ask your parents and your grandparents. Sit down and ask your relatives what happened to your relatives, so that you can tell your healthcare provider, because you may need to undergo increased screenings based on that health history. So keep a cancer pedigree and just write it down like you used to in front of the family Bible. And finally, I want to just talk about that breast cancer can affect women of all ages. I put this in here because many times we just think that breast cancer affects women who are 50 and 60 and 70 years of age. I can't say over and over again how often I see women in their 30s diagnosed with breast cancer. So that means when you're in your 20s, you should be talking to your healthcare provider about, am I average risk or am I high risk? Why is that important? Because if we find breast cancer early, before it is spread to the lymph glands and distant organs, because you've been routinely screening, and if you have an abnormality, you're seeking treatment immediately, survival, regardless of ethnic and racial group, is over 90%. It is when we start to get into regional disease and disease that is spread to other areas of the body, that we see a 5-year survival that is down to 24%. We want to be in this bin where we find it early and our outcomes are the best. So I want to tell you a little bit about what our Links chapter did in St. Louis during the lockdown with COVID. We had dedicated ourselves to promoting breast health in the community, but we were unable to go to our churches like we had planned to, and our social groups, and really talk about the importance of mammography screening and exercise and weight modification. And so we did a virtual educational message based off of Jada Pinkett's Red Table Talk, and we call it Pink Table Talk. And I don't have time to play it today, but this is our website. And we decided to be no holds barred. You could talk about anything, just like you would see on Red Table Talk. I'll give you a 60 seconds or less snippet of what I mean by that. And it is full of information on how to get free screenings and many of the tenets that I talked about today. So let me just play this quick snip.
How about having your partner, your husband, examine your breast? Does anybody? I bet. I think that's important. Many men have said at the time of an appointment, I felt this. I knew it wasn't normal for my wife. And so I told her. So I think it's okay for your partner to be a part of keeping you healthy. My cousin, who had a mastectomy, told me, she said, you know, my husband found it. She said he always loved to fondle my breast, and he said, you know, something's off. And so then she went to the doctor, and sure enough, she had a mass. You and your partner, do you get like a candle, some oil?
So as you can see, that was just one fun snippet of it, but we talk about everything from where to get free screenings to one of our survivors who was sitting around the table gives a story you'll never forget, but how she advocated for herself and really is alive because she did that. So just remember, a lot of times we have a lot of fears, and we decided to open up and talk about our fears and also have a good time at the Pink Table Talk. So I would like you to follow these breast health tips. Let's remember that 50 to 60 years ago, the most common cause of death was infection. It was pneumonia. And now we have an army of antibiotics that prevent that as our #1 cause of death. We have incredible advances in breast cancer treatment and great screening tools, but not if we don't use them. So I encourage you to know that you have much more control over your destiny than you think. And I want you all to live out your full life with choosing wisely and living bravely and loving deeply. So thank you so much for the opportunity to talk to you today, and my contact information is below.
Dr. Hall, we have a few questions in the Q&A. If
Okay.
you take a look at them. I think you answered, when should we start screening? One said, I have had 2 lumpectomies, was not cancer. Is it really necessary?
Yeah, so I'm gonna have read this long one first, and I want to answer that one first, and then I'll go back to causes of breast cancer. I think we touched on that a little bit. Actually, let me do causes first. So as we know, some breast cancers are related to a abnormal gene that can be passed down from one relative to the next, so from your parents to their offspring. So that mutation or change in a gene can increase your risk of breast cancer. Having a disproportionate amount of fat on the body, we call it obesity, increases the risk of breast cancer, primarily because these fat cells do not sit in isolation. They release hormones, insulin, and other growth factors that can lead to proliferative lesions in the breast. So carrying excess weight is not healthy for the breast organ. We also know that there are other risk factors like alcoholic intake, and then some very modest health, like whether you've used birth control pills, very low risk. We're not worried about that as much as whether you have a mutation or other strong family history that would impact when you should screen. Now
Dr.
let's
Hall, I don't want to cut you off, but I have been getting several messages that it's time for us to get off. I hope
Oh.
that you copied Dr. Hall's information, and she is wonderful about getting back with you. Dr.
Yeah,
Hall, I'd like to take this time to thank you for sharing such a wealth of valuable knowledge. You are phenomenal. A special thank you to our attendees, Black Health Matters, the Men of Kappa Alpha Psi Fraternity, and all of our sponsors. Please continue to enjoy the summit. Thank you.
thank you.